Good afternoon, everyone. My name is Amy Peets, and I'm a mental health consumer consultant at St Vincent's Hospital. Mental illness entered my life what feels like a lifetime ago, but it was in fact 9 years ago, late in 2007, when I was 22 years old. What began as a gradual distortion of the senses quickly progressed into the presentation of what is known as first episode psychosis. Psychosis refers to an abnormal condition of the mind, described specifically as involving a loss of contact with reality. As my condition deteriorated and the symptoms became increasingly severe, my parents quickly responded to the crisis unfolding before them. They contacted our local hospital, where I was taken, assessed, and legally scheduled under the Australian Mental Health Act. Being scheduled and admitted to that public psychiatric ward was no doubt the most terrifying experience of my life. Not only had I lost control of my mind and its faculties, I had now lost all legal rights to the process of what happened to me next. The treatment protocols and decisions that occurred in the 3 to 4 months that followed were so riddled with poor outcomes and major side effects that I lost all concept of recovery or healing as a legitimate goal whilst there. No one spoke to me about the psychological effect of the terrifying hallucinations I was having. No one gave me advice on how to survive that experience emotionally, or equipped me with the tools I needed to begin the journey from a very poor state of health to an acceptable one. The doctors simply prescribed me large amounts of psychiatric medications and gave me some very sparse advice here and there. I guess they hoped my symptoms would disappear with medication and I would simply follow them out the door. However, recovering from severe mental illness does not rest solely on the premise of minimizing symptoms. It also requires genuine emotional healing to take place on account of the damage that gets done during the time those symptoms are present. Open dialogue treatment is not in complete opposition to the use of psychiatric medications. It does, however, take a more cautious and measured approach to the introduction of psychiatric medicines into the treatment plan. This is due to the fact that psychiatric medications are not always effective at treating psychosis, and they pose a litany of potential side effects that also threaten the patient's well-being. The network meetings at the heart of open dialogue promote a treatment process that is transparent and collaborative. It is a treatment process that differs from others in its willingness and protocol to explore in more depth and from an unconditional position that which is affecting the mind of the sufferer. The network meetings are also an opportunity for those outside the patient, those relevant to the patient's recovery, to be finally recognised as such: the worried and caring parents, the concerned partners, the long-time family doctors and supportive relatives and friends. Open dialogue is an opportunity. Looking back on nearly 10 years of psychiatric treatment, I wish that open dialogue had been available to me when I became unwell back in 2007. I had a voice that needed to be heard. I was in the grip of relentless mental illness, and terrifying, confusing, life-altering content was flooding my mind. Open dialogue could have helped me deal with the shock and psychological trauma that accompanied the onset of my illness. I might not have developed PTSD, or the inner unease, the chronic anxiety, and the saddening flashbacks, all of which I still live with today. Open dialogue treatment might have seen my recovery be a lot swifter and a lot more holistic than it has been. It's not about completely changing the system, rather it's about introducing the patients to the system in a gentle way so that they can make better use of the existing and new services. Mental health treatment isn't a one-off consultation and you're done. Patients develop a relationship with the mental health system that can last for years or even lifetimes. The gentleness and transparency of the open dialogue approach allows people to tackle the challenges facing them in a much less traumatizing way. Thank you for your time, and I look forward to continuing the conversation on open dialogue treatment in the future.
Open dialogue was developed gradually in Western Finland from the early 1980s to the mid-1990s, where it grew out of a psychotherapeutic approach to treating and rehabilitating people with schizophrenia, known as the need-adapted approach. Like open dialogue, the need-adapted approach emphasized a flexible and individual approach to each person and their families, including family-orientated therapy meetings. Open dialogue extended the need-adapted treatment by implementing mobile crisis intervention teams and by developing the particular dialogical psychotherapy. Open dialogue gradually spread to the rest of Scandinavia, in particular Denmark and Norway, where it was established as a genuinely person-orientated approach to mental health. After a decade of being practiced almost exclusively in Scandinavia, open dialogue was taken up by the international recovery movements, who primarily embraced it in the form of peer-supported open dialogue. The rationale behind peer-supported open dialogue is to systematically bring the voice of a peer worker into the network meetings. In some circles, this approach is considered to be controversial because it's unclear how lived experience of mental health problems qualifies anyone to become part of a specialized psychotherapeutic intervention. And the most widespread solution or answer to this question is to train peers in open dialogue psychotherapy so that their contribution is not only having lived experience, but also basic psychotherapeutic competencies. More recently, peer-supported open dialogue has been rolled out in large-scale studies in the UK, the United States, Germany, and Italy. Open dialogue is new in New South Wales and in Australia. The approach has received a lot of attention. For instance, the New South Wales Mental Health Commission has invited a number of open dialogue specialists from Scandinavia, England, and the United States to give presentations and seminars. And more recently, the Mental Health Commission established an open dialogue interest group. However, the approach is yet to have its breakthrough in Australia. And the key problem in Australia is that there are very few open dialogue therapists and trainers. Very few clinicians have the capacity to attend extensive courses in Helsinki or in London. An initiative launched at the St. Vincent's hospitals in Sydney seeks to solve this bottleneck problem by bringing an open dialogue train-the-trainer course and an open dialogue certificate psychotherapy course to Sydney. The teachers of these courses are recruited from the original site in Finland. Our ambition is to establish several levels of university-based open dialogue education programs that can be accessed by both professionals and peer workers. Obviously, there are significant differences between the people living in Western Lapland and in New South Wales. And there are significant differences in the organisation and provision of mental health care. Adoption of the approach is not simple because it's not practiced by following a structured manual. Rather, as Christoph explained to us a little earlier on, it's based on 7 core principles. And this actually pushes the responsibility of interpreting and adopting the approach onto us as healthcare providers. We must work hard to find out how the principles might be operationalized in the particular Australian healthcare context. And this is why we're presently studying how open dialogue might be adopted to the New South Wales context. The study includes 4 mental health teams from Nepean Blue Mountains LHD and from St. Vincent's Private Hospital, Sydney. We're exploring how to interpret the principles and how it might be possible to roll out the approach in different types of healthcare services. These results from this initial study are key in the continual work to scale up the implementation of open dialogue in New South Wales and to test the psychosocial and economical effects of the intervention. I'd like to hand over to the final speaker, Nadia, who will introduce us.